but thank you so much for joining us for our handover event. So it's the last session of the Cancer Entity Improvement Programme, and you guys, again, are cohort 2. My name is Dua Abdullah. I'm a Programme Support Manager, and I work in the National Cancer Programme. And I'm also joined by a few of my colleagues, so Robin Cutforth, Matt Noonan, and Alison Poole. So just the agenda for today. So we're going to go through all of your wonderful presentations, your posters that you sent us. They look amazing. Thank you so much for handing those in. And then we are going to talk through some evaluation, and then we'll bring it to a close. So just some expectations. Please do keep your cameras on when possible. It's just nice to see your faces and to feel like we're all chatting to each other. Please do mute whilst people are speaking and presenting. Obviously, people are going to be presenting the posters today, so it would be great if whilst people are speaking, please keep muted. Please do actively participate. Feel free to put hands up, use the chat box. I feel like people will appreciate, being asked any questions after they present their posters. So please do that. And yeah, please do actively listen to everyone's presentations. And yeah, feel free to pop anything you want to in the chat function. Share any insights, ask questions, providing links, and please stay open-minded. So we'll get straight into it. And first of all, so each team is going to be invited to, introduce themselves, talk through your poster, tell us about what you've learned during this experience, any improvements you've made, any future plans. So that'd be really great to hear. And I've got a running list here of who's going in order. So this is based off also people have contacted us to ask us if they can go first or whatever. So here is our list, and we'll start with King's College Hospital. And we can also share your posters for you. So we've got them all in our presentation, unless you really want to share them yourselves. If you would prefer to share them yourselves, you're more welcome to, but we've all got them on the list. So can our reps from King's come offline?
Hi there, I'm Laura. I'm Cancer Performance Lead at King's. Thank you for sharing the slides, that's great. I'm joined by a couple of our working group today, Professor Krish Menon and Dylan Lewis, who's a consultant radiologist. Also Aisha Day from our local Cancer Alliance. I can't spot anyone else from my team on the call, but please shout if you're here. Yeah, just to give you a kind of summary of our project, actually, it's really very similar to the example poster that you sent round from the previous cohort. So it was interesting to see we're not alone. I think Sheffield had a very similar ambition actually at your last group. So some of the themes are similar to that, but we have spent quite a lot of time sort of defining our problems, auditing, process mapping, gathering data. We certainly haven't reached the end of any PDSA cycle yet. We're very much in the kind of beginning to go into the doing phase now. So I think one of the lessons is really that this has just taken us a lot longer than we thought it would. But that because the
Oh yeah, absolutely.
Sorry,
could people mute themselves, please? Sorry, Laura, carry on.
Thank you. But yeah, certainly, I think this is due to the sort of complexity of the issues we're grappling with. This is taking us longer than we had maybe initially anticipated. But we've got a really clear kind of plan now for what we want to achieve. So yeah, I'll just walk you through that in summary. So the background is that the King's HPB MDT is a tertiary MDT with referrers from all over the sort of south of England, southeast England and beyond. So the number of patients referred to the MDT is becoming increasingly untenable, particularly in the context of finite resources with cost improvement and workforce constraints, like something you'll all be really familiar with, I'm sure. But I think there's an ongoing theme that many of the core MDT members identify that there are opportunities to reduce the number of what we're kind of calling inappropriate referrals to the MDT in order to improve the efficiency of the meeting and to make sure that they're using their valuable time to only discuss the most relevant cases. So there's 2 MDTs per week, both lasting 2 hours at the moment, but very often the list exceeds the agreed cap. And the MDT also identified that the capture of staging data could be improved, and it was insufficient in meetings. So our two SMART objectives here were to achieve a 50% reduction in the number of inappropriate cases being listed for discussion at the HPB MDT by the end of Jan, and to ensure that 80% of MDT outcome documents on EPIC contain radiological or histological staging data by the end of Jan. So our methods, we undertook a sort of variety of methods to gather all of our information. So some of us did some observations, so both of the MDT sort of admin prep processes and also the MDT list and prep triage processes led by obviously clinicians. We devised a questionnaire and sent it to all core members and extended members of the MDT to ask them about their current feedback and some potential solutions that they might identify to just try and make sure that we were open to as many sort of suggestions and solutions as possible. We've undertaken audits of the EMDTs over several days to gather data on the number of inappropriate discussions and staging data capture. And then we've also obviously been meeting as a working group. We've engaged with our sort of specialty meetings to discuss some of the issues and so on. So we've tried to extend our engagement as far as possible. We also had an external network day for an aligned MDT last week, and the feedback of that was also sort of helpful and relevant for HPB. The images here are this is the one. The blue circle is just an example of our questionnaire that we sent to the staff, and the bar graph is our number of inappropriate referrals per MDT. So the inappropriate ones are in orange. Where are we now? So I think through going through all of this process and gathering data, we have a collective agreement from the MDT members as to the sort of themes and categories of inappropriate referrals, because obviously different people have different views of what appropriate and inappropriate is, but I think we now have a sort of collective agreement on that we can work with. We've obviously sourced a lot of data that we can then use to measure improvements as we deliver them. And we've got an action plan with short, medium, and long-term objectives, so everyone's clear about what we want to achieve. And our future plans are basically to deliver the plan and to obviously re-audit regularly as we test our improvements. So we want to see improved staging, data capture. We're going to update further our MDT referral form and associated sort of SOPs. We want to formalise more of a consultant-led MDT triage process. And also the processes for reviewing certain groups of patients outside of the MDT, such as benign cases. We want to look at implementing, we're on EPIC at King's, so we want to look at implementing something called EPIC Care Link, which is where local hospitals can be given access to EPIC to improve the sharing of documentation and referrals, to automate some of this sort of transfer of information, which takes an awful lot of time. We're planning to hold an HPB away day for regional referrals to share our learning, and then also to gather more feedback to drive future improvements. And we want to develop and implement some standards of care. So as well as the benign cases that I mentioned, we want to think about pathways for patients to go straight to outpatient appointment, which does happen already, but could we maximise that more so that patients can bypass the MDT? You know, what do we do with patients who are referred where there's no change on imaging, but they've still been referred for a review, pancreatic cysts, etc. So we think there's quite a lot of scope to standardise some of those MDT referral pathways. And then finally, in terms of what we've learnt, I mean, I've already talked about the amount of time that this has taken so far, and the availability of all of us as working group members, you know, was limited to some extent due to all of our conflicting demands, which has, I think, impacted more than we thought on the speed of our progress. There had already been some changes made to the admin processes around the MDT, so the referral form, the criteria, you know, we thought that would really help, but as it turned out, that work that we'd all sort of previously celebrated as a success hadn't really been sufficient to address some of the complex problems. So we need to go back to that and further improve it. But I think the audit has also shown that inappropriate referrals actually make up a fairly small proportion of the overall discussion. So that whilst it's an important project to lead on, we've sort of evidenced equally that the MDT isn't completely swamped with inappropriate referrals. So the potential to reduce that is somewhat limited, but we all still feel like it's the right thing to do. Brilliant. Thank you. Thank you very much. Any questions?
Wonderful. Thank you so much, Laura, to you and your team at King's for your work on this. It's really, really great to see. Does anyone have questions? Robin?
Hi there. Thanks so much, Laura and Krish and the rest of the team. That was a really fantastic presentation. I was just wondering about your the team questionnaire you did and the feedback, which sounds like a fantastic way to gather information on the MDT. I was just wondering if from that questionnaire there was anything that came up that was unexpected or new that you learned about the MDT from that feedback?
I don't think there was anything unexpected particularly, but I think it probably revealed that there is a range of opinion and ideas about solutions, which I think we probably wouldn't have teased out fully had we not done it. So we really worked hard to try and make sure that every single stakeholder group was consulted with. And, we wouldn't always, we might not always like what we heard from everyone, but it was important, I think, to open the project up to that level of feedback. Krish, did you want to come in?
No, thank you, Laura. I think I wanted to first of all thank Laura for spearheading this and doing a lot of the work and coordinating the efforts from everybody. So thank you, Laura, for that. And I think from the questionnaire and the whole process, I think the most important bit Robin we learned was that you have a pathway that's been existing for 15 years and you never looked at it too much. This sort of a project allows you to introspect a bit more, go back into those pathways. The diagnosis, the treatments have changed. So some of the stuff is archaic and you then revise that and that streamlines a lot more what comes through into your MDT. And we're hopeful that as we move forward with our future plans, that if you do this on a regular basis, it's a bit like the peer review that we do. But I think this allows you to therefore become much more effective in delivering your cancer MDTs. So thank you very much for this project, because I think what it has done is made us look at our pathways in a much more critical manner, where we used to think they were really good, but there's a lot of work that can be done to make it better for our patients. Thank you.
Great, thank you. Nero?
Hi, Laura. First of all, a very good work. A lot to learn from this presentation. I think I'm just echoing the thoughts of Krish. I had a question, Laura, like in MDT, this is for me to learn from it. MDT referral form has a radiology section in it. So what all questions did you put in radiology section to kind of deter inappropriate referral? It's just for my own interest.
Sure, we haven't actually changed it yet.
Right. Okay.
But but obviously we want to get more feedback on what we learned through the questionnaire, and the observation was particularly the fellows who are the ones actually triaging the list are saying that there are improvements that could be made to it. We've got Dylan on the line actually, who's our consultant radiologist at King's. Dylan, I don't know if you want to just come in to clarify what we consider to be our minimum data set for imaging.
Yeah, thanks, Laura. So I think the main issue for us, particularly with the pancreatic patients, is the time since the last imaging by the time the patient comes to the MDT with different investigations that have happened. So often by the time they reach us, that the CT is sort of 6 weeks, 2 months old, which in the case of pancreatic tumours is quite long. So I think we need updated imaging. I think a lot of patients don't have the full data set coming across, or inappropriate imaging just venous phase rather than biphasic. If there's a clear pancreatic cancer, maybe they should have had a PET scan by the time they get to the MDT. So there's a few bits and pieces to work out for the different tumour groups within HPB, and that's something that we're going to work on going forwards.
Right. Thank you. Thank you, Dylan. Yeah.
with permission, can I add one more point there, Laura? I think what we have changed in answer to your question, Niru, is also the SOP, so that the radiology bits within that SOP for a referral that's coming in, if they're not done, then they just don't get to the MDT. So in other words, if a PET is not done or a CT is not done, then that doesn't reach the MDT now until that pro forma in that tick box for radiology is complete. Because otherwise they end up to come into the MDT, getting postponed to the next MDT, and that's a waste of a slot.
Yeah, I agree with you. Yes, yes. Thank you.
Thank you. Richard?
Yeah, hi. Yeah, great work so far. I'm the skin lead at Durham. We'll be talking next, but just a reflection on how difficult all of this is to implement change. And actually, I've learned quite a lot from our hepatobiliary team up in the Freeman Hospital in Newcastle. They've developed this patient pass system. I don't know whether you've heard about that, but it's fantastic. It's all online, and I mean, for someone referring into HPB, you know, it's quite annoying because you've got to fill everything out, but it's literally for them, it's so straightforward because exactly this SOP that they've developed, it means you can't pass go or get any referral in unless you as the referrer has given all the information. And I believe that because it's a huge tertiary service, that's even within their own hospital trust as well as outside. And I've mentioned it before, I think, in this group, but the fantastic part about it is if there's not enough information, actually the consultant or whoever is overseeing the patient pass literally does little text messages to me as the referring consultant. Just say, yeah, can you just update me on the histology? We haven't got enough information. And then you text back into that patient pass. And then basically by the end of it, the process seems really, really very fluid. I'd love to know how they set it up. So it's probably something I'm going to look at going forward. I know that our burns service as well, MDT, is also looking to set something up using this patient pass system. So as long as you've got your SOP and you've got somebody overseeing it, and it's normally the consultant, transplant guy or whoever it is who's looking at it, or HPV consultant, rather than fellows, and the system seems to be really very fluent. And I think especially for a big tertiary service, it's something to learn from. So yeah, so if you know, from a learning point of view, I definitely recommend asking the HPB guys up in Newcastle, Freeman Hospital, for how they set it up, because I'm definitely also going to look at that for my skin service as well.
Great, thank you, Richard. Krishna, did you want to come back on that?
Yeah, so I think thanks for that, and we will take a look at it because I know the guys at Freeman very well. But the other point I wanted to make, if I may, is that we've done all of this in the past 5 to 6 months by being 2 whole-time equivalents down. So for our kind of a service, which delivers a massive amount of HPB and liver transplant, and we did 277 liver transplants last year in addition to the HPB, we're only 6 consultants, we're 2 whole-time equivalents down. So despite that, you know, we managed to pull through all of this. So it's a lot of work, but resource constraints are a big challenge moving forward. So we're hoping to get that resolved in the next couple of months. Thank you.
All right, thank you so much. And thank you to Kings for all your work that you've done. And thank you for all the questions, everyone. So next up on our list, we have Mersey and West Lancashire.
Good morning, everyone. My name is Mo. I'm one of the consultant urologists at Western Hospital. So Mersey West Lancashire Trust has emerged 2 years ago, over 2 years ago, from merging 2 separate trusts, which is St Helens and Knowsley, and also Southport and Ormskirk. So we cover a large area, 4 hospitals, 2 acute sites, and we used to have, well, we still have 2 separate urology MDTs, and we're trying to merge these together and try to see what improvements we can make, and therefore we joined the program. We are not tertiary center or pelvic center, so we compared to the previous presentation, we have relatively smaller cancer MDT, but again, nevertheless, it's involves all cancer sites in urology. So what we did, the names in the up there shows that the group that we created, and we joined the meetings, such as yourself, every 2 weeks for the last few months. And separate to that, we did our own once monthly meeting where we discuss ideas and we come up with the plan of what we need to do over the next month, and we made a working document that the summary of it is shared here with you. The reason we joined is obviously there is an increase in number of patients we discuss in every MDT, and I suppose that's same for everyone. But mainly, as I mentioned, in 2023, the merge between two sites meant that we need to work together to have to align our services and align our MDT pathway, referrals, and outcomes. And happened to be that we both do our MDTs on the same day, one after the other. So timing-wise, that worked well. In addition, the regional standard of care and streamlining has been published by Cheshire and Merseyside, and nearby hospitals started to implement, which we haven't done before we started the program here, and therefore we wanted to be pioneer in doing so. In addition, the referral to MDT was quite not formalized, and I think, as my colleagues just mentioned, about as much information needed or provided to go through the MDT will be essential to discuss the cases, and therefore we try to unify our MDT pro forma and referral process. So in terms of methods and outcomes, as I mentioned, we do one monthly meeting and we brainstorm the ideas. So instead of doing a questionnaire, we actually met with all stakeholders, and in advance, everyone written their ideas, brainstorming what their wish list is and what we think we can do. And then I try to categorize that into separate headings and subheadings and work our way through over the last few months. We looked at some realistic and achievable goals. Clearly, the trust going through a merge between two big trusts, and also the services need to be aligned, workforce issues and other things. So we try to make sure we look at realistic goals that things we can achieve within short time, and also have some aspiration to do other changes in the future. So we try to make sure we write those as well. In the picture, you can see the two hospitals, Southport and Wiston, where the two MDTs run on Thursdays. In addition, the one next to it is the MDT pro forma, which we unified and shared as a Word and PDF document. So any referral comes from any other disciplines or within the hospital or outside the hospital, in both sites, they need to fill in this form and submit it to the MDT coordinator or the cancer nurse specialist. This will provide information enough that it passes the cover test. So the person who knows the patient or refer the patient, if they are not available in the MDT, the team will be able to read this and have enough information to make some judgment and have some outcome and decision making. So that's one of the things that we achieved within that short time. In addition, we have been in touch with Cheshire Merseyside Cancer Alliance, who've been very good in providing an independent audit into our MDT. So they linked in to our both MDTs over a 3 weeks period, and they have set criteria of what information they need to collect anonymously without involving patient data. And then we met with them. They shared the outcomes, pointing out where the delay is, what things that could be done better, how can we improve by reducing the list, what about the MDT lead, house rules, and also which cases could have been standard of care and streamlined, can be taken out. Are there any benign cases we are discussing that we should not be? Any cases that could have had radiology virtual discussion beforehand that we could have trimmed out. So all of this information we got from Cancer Alliance through an audit. and we managed to work through that and start implementing. We managed to secure 1 PA funding from Cancer Alliance for 1 year, which helps to do the streamlining and pre-MDT review of cases. We started that 3 weeks ago. And what we did is we said, well, for the next 3 months, we'll pilot the streamlining and standard of care meeting ahead of MDT, usually 2 days before. And we look at both side MDT and mark the cases that we could eventually remove and give a decision of what the outcome should be, and then still keep them in the MDT for quality check and see what the MDT decides for those. And in 3 months, we'll be able to look at those and see if there is any discrepancy, or are we aligned and are we happy that these cases should be removed totally from MDT. What we agreed is that we don't actually remove them. We leave them at the end of the list, marked in a different color and say standard of care or streamlined for everyone to see and make sure they agree with the plan. So what we found so far, having implemented that pilot, is we could reduce the MDT for each side by about 50%. In fact, if we involve a radiologist in that pre-MDT review, we could reduce it up to 2/3 for each MDT. It's quite massive number, though we have to be a bit careful that we don't end up dilute the benefit of having an MDT. So we're trying to be careful of what cases that we can remove from MDT, which ones are not, and we leave that for the audit in 3 months to conclude and then decide. But regardless, I think what we found from this is that we could potentially reduce a significant number from both MDTs and then have one unified urology MDT across all sites. That will reduce the workforce required for MDT and reduce the number of people, job plan time needed for 2 separate MDTs as well. And also manage to get the benign cases and standard of care cases signed off early, and so they don't have to be brought back to MDT each time. What we've learned from this is that every member of MDT, regardless what their role is, they're essential. And I think there are some easy wins we can get without having to involve a lot of resources, and some long-term goals we have in mind. We have a vision for, and we thought about doing those in about 6 months to 9 months, depends on how things goes. But at least we have a clear path of what we want to achieve within a year. Standard of care and streamlining is something that is the core of what we achieved, and I think that will help to reshape our MDT in a big deal. So the future plans I mentioned within a year is that we implement standard of care fully. We have a meeting where there is a CNS and maybe radiologist virtually and a urologist. And also we're going to see if there are enough virtual cases or benign cases to justify doing a benign MDT once every 2 weeks or so, to get these cases discussed separately. And ultimately the goal is to have one MDT for all sites. I think that's all I wanted to mention, but I'm open to any questions from anyone, please.
Thank you so much, Mo, to yourself and for your team at Massey in West Lancashire. This is really great to see. And I think when you've got something so big like a merger happening, and the need to work together is so important. So thank you so much for your work. And we've got questions. Nero?
Yeah, thank you, Mo, for a lovely presentation. I've got 2 questions. First, who all were present in the pre-meet? Who all were the members of the pre-meet when you did?
So at the moment, it's piloted, so we have not fully implemented. So it's currently running by a urologist who has experience in cancer service, not necessarily surgery. But I think the idea is that when we implement it, which will be in less than 3 months now, is ideally should have a CNS and urologist, a radiologist, if we really want to make sure we take some of the prostate cancer cases as well. not necessarily pathology, because the reports will be available and we can go back to the team and discuss. But I think realistically, 3 people will be urologist, CNS, any radiologists for cases that we need them for, or maybe they will be available to discuss virtually. It's not finalized yet, but I think that's the vision.
Right. Yeah. So yeah, that's the only question. The second question then is not valid now. Thank you.
Thank you, Nuru. Next up we have Francois. Sorry, if that's not it. Is it Francois?
Yes, it's Francois. Thank you. Thank you, Mo, for your presentation. It's Francois from Leicester. You mentioned that we're going through the same thing where we're starting standard of care. But you do the thing where, what did you say, like, instead of signing them off straight away, you still keep them on, but so that people can see, and then if they're okay with it, you mentioned it, I think, in one of your
Yes. So basically, we looked at other trusts in urology. What they do is they fully implemented standard of care. So what they do, excuse me, they keep them at the end of the list, and it does say standard of care cases, and says they've been signed off, and this is the plan. Probably in a different color or a mark to say standard of care cases. So they don't need to discuss them in MDT, but they remain on the list for 2 reasons. One, for everyone to see, and if anyone unhappy with the decision or just think they really still need to discuss them, they discuss them. And also to be, it's a documentation to show that they've been to MDT/standard of care, and they can be recorded on the cancer services as a cancer case. We follow very strict criteria for these cases. We have clear documents from Cancer Alliance, which shows which cases we can discuss, which ones are not. And I think one of the meetings we had here, I remember, and I think the key thing I remember from that meeting is that if any case with any doubt, still discuss an MDT. So there is no doubt about it. So we try to be more risk adverse and try to be very careful of how we implement it. Ultimately, the goal is not to, as I said earlier, not to dilute the MDT and remove 70–80% and then end up with no cases to discuss, but mainly to reduce as much as possible safely to make sure that the MDT, you spend more time in MDT discussing complex cases that need discussing.
Thank you.
Wonderful, thank you. Any other questions? Well, thank you so much, to the team at Mersey and West Lancs for everything. That is great to see. If anyone has any questions throughout the presentation, feel free to pop them in the chat as well.
Thank you.
Thanks very much. And next up, we have Guy's and St. Thomas.
Yes. Good morning. I'm Georgina Pizzaco. I'm one of the consultant breast surgeons at Guy's, and the MDT lead, having taken up the role later 2025. And I'm joined here by Laura Burns, who is one of our hardworking MDT coordinators. More members of the team would like to join the meeting, but they could not due to clinical commitments. So our background is that we have been having 2 cancer breast MDTs at Guy's per week, with different members of the MDT team attending in its meeting. You can see on the photo a fraction of our MDM. We also realized while making the poster that we don't have any updated photo. So this was from our away day last year. Some members of the team are no longer working with us, and we are much more extensive team. If we add all the oncology, radiology, histopathology, surgical MDT coordinators and breast care nurses team, we're about 45 people. So the 2 MDMs with different members of the team attending. That was a challenge because we had increased number of cases discussed in MDM, but we had also increased number of rediscussions, and the outcomes were not always consistent when discussed in a different MDM. We are a tertiary center. We have a high number of external referrals from the Southeast London and beyond, many of which have very complex pathways. Our MDMs have been overrunning, and overall the performance of the MDM, but not only that, it's multifactorial, has been affecting our cancer pathways performance. So our focus has been to improve the MDM efficiency by streamlining the discussions, having a consistency of the MDM outcomes, being consistent with the timings and efficient, and avoid rediscussions. And as an ultimate goal, of course, we have the improvement and optimization of our patients' cancer pathway. What we have done during the last months has been weekly MDM improvement meetings with the representatives of each team, and also representatives of the management and higher rank leadership team of our trust, where we have recognized and discussed the issues, and we have been trying to reach an agreement about the solutions and further steps. This has also helped with better engagement of the multidisciplinary team. We have restructured our two weekly meetings to become case specific, and this has improved the efficiency of both meetings. We are not overrunning anymore, and we have more time to discuss the complex cases. The whole team feels that this has led to an improvement of the efficiency of our MDMs. We have introduced pro forma for some of the external referrals, and we have been triaging all the external referrals by either myself as MDT lead or our breast clinical lead for breast surgery before adding to the MDM. And this has led to streamlining of the case and avoiding rediscussions, because we make sure that the referrals are appropriate, and our MDT coordinators also are very much on board to make sure that we have all the information we need before discussing. We have updated the SOPs for some external referrals, such as screening and referrals from a particular trust, USAM trust, which cases we take over at Guy's, and this has improved the patient's pathway and experience. Where we are now, we have 2 functioning multidisciplinary team meetings per week, with improved efficiency, good timings, and less rediscussions than very recently. We have been streamlining the cases for discussion, and we have agreed, following extensive discussions and a lot of effort from all teams, to work towards 1 main cancer MDM per week, where the majority of the team will be present, and the people who will be present will be consistently present, and this will lead to better outcomes and more consistent outcomes. So our future plans are the 1 main cancer MDM. We have a provisional starting date, the 16th of April. We continue working on MDM streamlining and standardization of cases in the same way that previous teams mentioned the standard of care. We will continue monitoring our process and our efficiency, and the improvement will be an ongoing project. We are looking into developing an SOP, which unfortunately we have never had. And we want to organize educational MDT specific days. So we have an annual away day for the breast at Guy's, but we want to organize specific days to share and exchange and learn from our MDT process and outcomes. The lessons learned similar to previous teams, and I have to say now that it has been wonderful to be part of the program. Thank you very much, and has been very reassuring and motivating to see that different teams are facing very similar challenges. So our lessons have been that the changes are possible despite the initial resistance, but they take time because nobody wants to change something that are used to, although it is recognized that it might not work very well. It is very important to have the engagement by the whole multidisciplinary team, otherwise changes feel as imposed instead of agreed. We have to celebrate small wins because this is very motivating, and the feedback by every member of the team is necessary because everyone's opinion matters, and all ideas can be implemented when they are helpful for the improvement of the work as a team. Thank you very much.
Sorry, I just wanted to add, hi, I'm Laura from Guy's Hospital, MDT. Georgina's worked very hard on this project, and her help, we wouldn't be able to be where we are without her. This massively helped our MDM team when prepping for MDMs. Rather than having all the patients, so like you got the post-op patients, biopsies, discussions, it's helped us manage our time a lot better. So we have a more structured week and a more structured day. But yeah, we're really excited to hopefully on the 16th of April turn it all into one MDM and improve our pathways for our patients.
Be under the same roof. Thank you, Laura. So I have to say, and it is the very truth that we have a wonderful MDT coordinator team, and they are really very hardworking and very motivated. And we could not do any of the changes without this team. So thank you very much, Laura and team who cannot be present today.
That's lovely. Thank you so much, Georgina and Laura and the rest of your team at Guy's St Thomas for your work on this. I think it's really, really great to see you guys working so well together, and yeah, looking forward to seeing what you do in the future. Does anyone have any questions for Guys? Robin?
Thank you. It's not a question, it's just a comment that actually, streamlining 2 MDT meetings into one is just a massive achievement and really well done. It's really, really positive to hear how you've all worked together on the project and put in so much time and effort into it. So yeah, I just wish you luck for the 16th of April. Hope it goes really well, but by the sounds of it, you'll really set up really well. So yeah, just thank you for sharing all that and good luck.
Thank you very much. We need it because it's going to be something very, very new for all of us. So we're very hopeful, and we hope it will go on well. Thank you.
Best of luck. Does anyone have any questions or any comments? Like I said before, please feel free to pop questions in the chat. But yeah, thank you so much, Georgina, Laura, and the rest of your team at Guy's St Thomas. Good luck with everything. Thank you. So next up, I've got my list already. Next up, we have County Durham and Darlington.
Yeah, hi, it's Richard. I'm the cancer lead for the MDT, specialist skin MDT, and also for the Northern Cancer Alliance. I just want to echo what everyone else has said, and probably will do afterwards, just the importance of actually having a great team. We really strive to kind of improve our MDT, and I think without all the team members on our poster, we've got 4 of them online today, so we've had a really good buy-in from the improvement team who've been asked to contribute, and it's been really great. So we've kind of been very interested in streamlining for a long time. We've done a couple of initiatives even before this, but this has really kind of kick-started us again to try and make more improvements and make them stick. So we've had some standard of care documents for our thin melanomas, for example, which we did an audit back in 21 and reduced our melanoma discussions by 16%, just by doing this very, very simple change. We added it to the end of our histopathology reports, so they're double reported, and at the end it says standard of care excise to 5 millimeters or 10 millimeters, depending on the staging. They do appear in the end of our MDT as information only, so it's documented there. But actually, we found we don't need to document them necessarily, and we do regular audits on that section to make sure that the standard of care is carried out. The second thing we've been doing is, unfortunately, we have our MDT every Monday, and we lost 6 on average, a year because of bank holidays. So we did an interim one, just normally with myself, Daniel, our MDT coordinator, Niru, our radiologist, plus or minus a pathologist. And so we kind of had 5 times a year. We've been doing a pre-meet type scenario, so not quorate, but we were kind of getting the idea of actually, you know, because before we'd implemented an interim meeting, we were just dumping another 30 cases on the following Monday, you know, especially around Christmas time, Boxing Day, etc. And it's just a nightmare. And so we kind of had started that streamlining process. So we knew a pre-meet was pretty useful. But anyway, with this process that we were getting on with, we're a tertiary referral centre for skin cancer. And through a couple of meetings with the whole team, we did some value stream mapping, and we were able to really identify where we're slowing down in the process. And a key concern was, like everybody, we're just MDT is too long. We're at the end of the day as well on a Monday, and actually even before we started streamlining, some people had to go off and actually leave the meeting to pick up kids if it goes past 5:30. And then if that's the case, then you're deferring to the week after. So something needed to be done. So we wanted to, with the group, we all decided that the radiology section needed to be looked at, because we felt that was the area to focus on within our MDT list. So we had a couple of phases. We performed a retrospective audit of all our cases over the course of 1 year, August 24 to July 25 as our benchmark. And we've got a pie chart there just for some nice colours. But we identified that 40% of the list was information only. Now, we don't discuss those. The radiology oncology section was 26% of the list, melanomas 15%, and non-melanomas 19%. Sarah, one of our CNSs, she also did some timings for these. And basically, we discovered that radiology represents 44% of the cases discussed. On average, in our MDT, radiology took 4.5 minutes per case. So you can imagine just having an extra few cases will add a lot of time. So the goal really was to improve our efficiency by streamlining, particularly the radiology section, ensuring focused discussion just on the complex or urgent issues. We created a problem statement which did help actually kind of focus our attention. So the specialist skin MDT cohort recognises that MDT is too long, specifically the radiology section. The average number of cases discussed in the meeting for radiology was just under 14 cases per meeting, representing 44% of the meeting overall. This did result in prolonged meeting durations. What was really interesting looking at the audit was just how there's so many peaks and troughs throughout the year. Sometimes we're discussing 30 to 40 just in the radiology section, which is just untenable. So the phase 2, we regrouped, and then we kind of discussed possible reasons for the inefficiencies, which has been echoed by a lot of the speakers already. Mainly inadequate information provided, no clinical question given for the radiologist, incomplete imaging, incomplete clinical information, unnecessary or non-urgent routine staging scans, for example, which were all normal on the list. Nothing that required an MDT team discussion. There was a pro forma that we do use, but it's probably not been used enough. The screening of that is probably not robust enough, and certainly it's often incomplete. And one of the big areas that I think a lot of the teams mentioned was that not all test results, such as pathology, were back. So we'd perhaps discuss radiology, and then we go bring back next week when pathology is ready. But then that's just discussing radiology. It's not an MDT plan because not all the information is there. So we were kind of pushed into trying to make change happen very quickly, which is extremely difficult and does require a lot of buy-in. But along with Daniel, MDT coordinator, and especially Niru, our radiologist, who obviously has a vested interest in improving the radiology section, we've really kind of focused on trying to get a very organised pre-meet. So we've done 3 pre-meets. I've updated the slide so I can kind of send one over later. But we've done 3 pre-meets since we implemented this, 15 minutes prior, comprising of the clinical lead radiologist, and MDT coordinator. We have been just going through each case in the radiology sections to kind of look at what we should include, what should we exclude. Can we just give an outcome outside of MDT? Does it need discussion? And that's kind of the early part of our decision making. So our early results, we've had 3 MDT meetings. In the first meeting, we had 21 on the radiology section to be discussed. 9 were triaged out of the meeting, so a 42% reduction, saving us 30 minutes on that MDT. Another MDT meeting, we had 24 radiology listed. We were able to triage out 4, which is a 17% reduction, gaining us about 13 minutes. And the last one, just on Monday, we had 11 cases, 1 triaged, 9% reduction. What's kind of interesting, and obviously we're going to do this prospectively, keep looking at our timings and reduction. Our average time per case since we've been doing this for radiology has been just over 3 minutes. But the case is now for Monday was down to 2 minutes. Now, I don't know, it's only n equals 3, but are we already becoming more efficient with our discussions just because we're looking at it? Very early to say. But yeah, there's some really interesting early data coming out. So already future plans, we've seen a reduction in the cases already, which is really, I think I totally agree with the last speaker, celebrate the small wins. So I think already we've got a couple of wins going on. We're developing a specific standards of care protocol, particularly for radiology. And I think as part of our improvement with the pre-meet, I think we're going to make sure that we've got a very robust pro forma with all the questions, all the clinical features included, and they will not be discussed if that's not filled out. What we would like to do is at some point perhaps hand over the triaging away from the clinical team, perhaps to the MDT coordinator, as long as they have a very robust standard of care to do it. Because clinical time is very difficult to kind of 2 consultants to get an extra 15 minutes. It doesn't sound much, but I've had to move lots of things in my diary just to do that. So perhaps giving that power, as long as they've got a very robust pro forma, then we will back them up on that. So that's probably the next phase, and Niru has been working on the pro forma even this week, I believe. So and then just future plans. Yeah, we've recognised that even within the non-melanomas and melanoma cases. There's so much of standards of care that we can introduce. The only issue is, how do we record it in an MDT? Must they be recorded MDT? That's something that at the Alliance we're looking at to see whether the standards of care are robust enough, so that they don't have to be mentioned in an MDT outcome. Personally, I think many of them don't. And we are also setting up 6 monthly audit meetings for the skin cancer governance, to discuss morbidity, mortality, which we don't do at all very well. And equally, we'll be presenting these improvements and I guess audits regularly in those meetings. So yeah, I'm really proud of the guys, how we've kind of achieved this so far. But we've learned some lessons, I think. Do not underestimate project fatigue and loss of momentum. This is something that I think, it was useful for you guys to kind of keep nudging us with emails and having the one-on-one sessions just to kind of go, how are things going? That's been really useful. But yeah, it takes a lot actually to push these things through and keep going. It does not happen overnight. Delegate, engage key members to take part. Hence, radiology for me, Niru's done a sterling job to kind of really try and drive her radiology section through, which is excellent. An early buy-in from senior management is important. So we've not necessarily been given extra time, but even I spoke to my chief executive about the audits, and he was like, look, just do it. We will support governance. We will support you increasing the number of meetings for the MDT. Just get on and do it. And so that's been really encouraging from our side. So yeah, some early wins, which is great. And yeah, I really appreciate being part of the improvement program, because it has helped support us. So yeah, that's us. Thanks.
Wonderful. Thank you so much, Richard, and to the team at County Durham and Darlington. It's really great to see that you've seen some improvements so far. And I think pointing out the fact that, change doesn't happen overnight, and we're really grateful to you guys for working on this project and for being open to our 1,000,001 emails that we send out at times. I think it's been really great that everyone's participated. But yes, as I said, change does not happen overnight, so it's great to see. Does anyone have any questions for Richard and the team? Matt?
I thought the problem statement thing was really interesting. So as a team, was that something you sort of set out to at the start, or was it a sort of byproduct? I think that's having something to sort of focus back on, I guess, is quite an interesting thing. So just to understand a bit about how you sort of decided that was the thing you're going to do, and how you sort of came up with it as an MDT.
Yeah, thank you. To be honest, it was just, I think, based on maybe the first meeting we all had here, and I think it was just come up with your problem statement. And what was nice is that we all then met after that first seminar thing and just said, look, let's get a problem statement going and let's see what happens. And actually what was really interesting was the one-to-one mentorship that we had as maybe the leads. Not everyone got that, which I thought was, which I appreciated. And the problem is, when you're an MDT lead, like myself, you sort of want to change everything immediately, and you want to crack heads and just get it done. Whereas the mentor was like, hang on, just focus on one thing and be very specific about that, and give us some evidence as to why that is important to you. And actually, one of the take-home things that I'll probably take forever in my career from this is measurable change. And I think that's why we wanted to get an audit of where we were, and then actually by then auditing your progress, you can show that there's change. And I think that's so important for anything, because if you're dealing with managers and people who aren't clinically driven, A lot of it is, well, why is it important? Well, this is why it's important, because we're taking this long in radiology section. We're reducing it by half an hour already by our implementation. And that's the kind of figures everyone understands. So yeah, so the problem statement was driven by the improvement program itself, and then it was really honing it in to make sure we're really very focused on what that was, and make sure we've got evidence so we can do a measurable change for improvement. So yeah, so that was it.
Brilliant, thank you. Yeah, I completely agree around the measuring stuff, because it especially early on, being able to celebrate those small wins you described is really important, because it can snowball. So yeah, that's brilliant. And thank you so much. Yeah, I think you're probably the first person ever to thank NHS England for an email. So we'll put that down. But yeah, really appreciate your comments and your thoughts and your work. It's been amazing.
Thank you. I was thinking the same, Matt. Usually it's please go away and stop emailing us. So it's nice to see. Yeah, thank you so much, Richard, and yeah, to the team at County Durham and Darlington. It's really, really great work. So next up, we have Salisbury.
Hi, it's Max Johnston here. I'm just in a corridor on the way to the office, so I don't suppose I can have a couple of moments or someone nip in ahead of us.
No, that's absolutely fine. We can swap you around if you want. Next up, we have the Nobles Hospital. If you guys can go next instead.
Thank you.
All right.
Hi, so we're the team that meets all together. So we're going to take it in turns to present parts of our poster. So I'm Strava. I'm one of the colorectal consultants, and I was leading on this project. And with me, I have Carol Kringle, who's our colorectal CNS, and Victoria, who is our colorectal MDT coordinator. So the background is we're one of the largest MDTs within our organization, and we have quite a high administrative workload. So we were looking to see how we can improve efficiency, data capture, and our working within the colorectal MDT to streamline things and use lean principles. The challenges identified were around radiology and diagnostics largely. We had delays in reporting. We also had challenges with data capture and our MDT prep times, as well as referrals and the pathways thereof, as well as vetting time. So we found as a group, when we did our self-assessment, that we were doing a lot of things that were required for an efficient MDT. However, our policies, our terms of reference, they were all a bit outdated and needed updating, as well as adding elements to it, and re-looking at the job descriptions and redefining jobs that we did within the team. And we needed to also introduce training, because whilst we were doing things, we didn't have the formalized training for it. So we scored ourselves quite harshly, and unfortunately, our scoring hasn't improved greatly, because we still scored ourselves harshly, because within this time that we've been doing the improvement program, we went for quick wins alongside to run in parallel with our longer term plans. And the updating of policies and updating of terms of reference fell in our longer term plans. So we had somewhat limited resources in that for quite a large cancer site, we have one colorectal CNS, which she also covers all of bowel cancer screening, and she covers the stoma care. So that's quite a heavy workload for one person, and also in some ways is our single point of failure if something happened to Carol. So we wanted to ensure that we had processes in place, particularly with the surveillance patients and the way we captured data for our surveillance and coordinated it. Because when we looked at this process, we found largely that work was being duplicated between our CNS, the MDT team, and also our administrative team. So participation in this program was to address these gaps. We've identified a lot of challenges around our workforce capacity and also our governance, which we wanted to rectify. And as you can see, we've put where we scored in our self-assessment. So I will hand over to Violetta.
Yeah, thank you. Yeah, so during the first two sessions that we had with you guys, the focus was on the MDT streamlining with the quick wins being introduced. And these insights have been taken forward, and the decision was made by our team to prioritize the delivery of these quick wins during the program, while also establishing clear long-term goals for future achievement. And consequently, the methods and outcomes outlined have been identified as achievable quick wins that support immediate improvement alongside the long-term process. So I'm going to go quickly through our methods and outcomes, or as we call them, quick wins. We've subdivided them into three larger categories: radiology and pathology engagement, workforce governance and preparation time, and innovation and infrastructure. So as the MDT team, we met with local radiology and pathology teams to review ways of working and gather feedback from them. Then provisional MDT list distributed in advance to highlight outstanding radiology and pathology investigations. The radiology investigations are now requested during the MDT meeting, with radiology assigning candidates at the time of the discussion. So that reduced the delays by enabling patients to be informed of the required investigations and confirm candidates during their appointments where we deliver the MDT outcome to them. We've also got a weekly colorectal governance meeting, and it is used as a forum to monitor changes and share improvement ideas. And colorectal MDT improvement was added to that as a standing agenda item. We've also appointed the Associate Medical Director of Cancer with job plan reviews planned to support MDT preparation time. We've created a shared MDT digital area to reduce paperwork and improve access to MDT related information. We've also introduced some AI tools to support MDT coordination and workload engagement, and our MDT coordinators have been enrolled in a co-pilot training. So we've got some trial licenses issued to all the team members, and they're currently undergoing some training. Where we are now, so basically we've reviewed and redesigned some of our key MDT processes. We've improved the list structure and the circulation timelines. We continue the ongoing engagement with our radiology, pathology, business intelligence, and the hospital management. We've established some shared digital workspace in daily practice, trial introduction of AI tools with evaluation ongoing, started policy review and development work, and also embedded MDT improvement within our governance structures.
Lessons learned from the improvement program. The biggest one that I've definitely got is reassuring that we're all facing the same challenges, and it's nice to know that we are doing some things that are right. It's just we have to tweak them here and there. And it was the early management of the radiology and the pathology is critical to the MDT efficiency. We made small administrative changes, and we realised the lack of protected MDT preparation. That's still being looked at, because it needs to be that we need to be looking at job plans, and yeah, sharing the digital space, which can be a problem for some of us that are not very good IT wise. And yeah, I think we're doing well. We've learned a lot from it, and yeah, I've enjoyed the experience. And then over to you, John.
So our future plans and what comes next. Well, Violetta alluded to us appointing an associate medical director for cancer, and I'm glad to say that's me. So we have achieved something out of this program, because a lot of the work we did here was used in my presentation. So with the AMD post, it is across all sectors. So it's across all cancer sites and includes primary care and tertiary care, community screening and liaising with the government. So I think a lot of the lessons we've learned here, we're now looking to set up our own MDT improvement program across all of our cancer sites and across all sectors, and use a lot of the learning, to work across all of our cancer sites. So we've developed and updated our MDTs, our PTLs, and we're looking at retraining and competencies policies. I've also been working on our budget for 26-27, and we've ensured that some of these have been included in our new budget. And further development for role clarity, this is an area that we're looking at very closely, because we're looking at ensuring that we're using the correct people in the correct places within our team, and rebranding our MDT team as a cancer team, not just the MDT team. We are continuing, and we have really good executive buy-in to enforce our leadership, engagement and our improvements within the MDTs and the cancer sites. We are integrating and talking to both ED and GPs constantly, as well as public health about screening. And we're looking at all of our MDT groups now, not just the colorectal. And we've also now gotten some add-ons. Apart from AI, we've got add-ons with SCR that we're looking into. And we're looking at, one of the biggest problems was our surveillance pathway. So we're looking at getting or introducing RMS to help with that. We're continuing also to look into digital transformation, and something that I'm trying to push for is live dashboards, because I think they far more effective in capturing our data than the methods that we're currently using. So we've got business cases in progress for our new interventional radiology room, and that is progressing well. And we've also got an increase in the radiology workforce, which was projected and will help our services across all cancer sites. We did really well with our colorectal governance meeting, and we're looking to introduce that to all of our cancer sites, because that helps you look at what your quick wins are and what you can improve within the team. And what else did I say? So we are also joining a tertiary colorectal center, and we are forming a rectal cancer group, so that we will have more standardized practice and standardized performance. And I'm glad to say that fortunately we have a very motivated and innovative team within our cancer services, and we're not afraid of change. We're quite change agents, and I think we've got some trailblazers within our team. So we're very excited about how we take this forward. Thank you.
Wonderful. Thank you so much to everyone at Nobles. I also really love seeing you guys in the room together. It's just nice to join that way. But yeah, it sounds like you've got some really, really great plans ahead of you. I'm really excited to see what comes next. Does anyone have any questions for the team? Robin?
Thank you. Firstly, just to say that your project is actually music to my ears, because I talk a lot about the importance of governance. So I'm really happy that it's been able to support you in your improvements. Really fantastic. I was just wondering about your radiology investigations being requested during the MDT meeting. You say you've experienced some reduction in delays for patients around that. I was just wondering if you have any plans for an audit in the future to perhaps measure the impact that's had on patient pathways.
Yeah, so part of, one of the things that we've done with the improvement and me taking on a new role is that we have introduced a full audit program within all cancer sites, ensuring that we are updated with national audits, but also looking at patient-related audits and outcomes. We're also auditing our MDTs and how we function and all of the changes we made. So there's a lot of work that is being done, and therefore I have asked for, when I'm asking for extra funding for a cancer improvement manager.
Fantastic. I think just a request, if you have the results of those audits in the future, I'd really like to see them. So thank you so much.
Perfect. Thank you.
Wonderful. Thank you. Richard?
Yeah, hi. Yeah, really great work already. It's sounds like there's a real momentum going, as we discussed for us. So really commendable for all of you. A couple of things I was just really interested in. I mean, just the very last thing about the radiology referrals being done in the meeting. We did a review of this a little while ago. We did a real deep dive into the full skin pathway from referral into being treated, and there were significant delays with things being acted upon, so MDT actions, and it ranged from kind of 0 days, as in people do it then and there, up to at least 14 days if people were away or whatever. And so that's a huge amount of time. So yeah, that's a really important point that I'm really glad you sort of have started looking at, because that's definitely part of our SOP going forward. And then the final thing, you sort of mentioned the AI, and obviously it's a big digital kind of revolution coming up. I'm just wondering what kind of AI things you were thinking about, just for the group.
So do you want to take AI comment, and then I'll just make a comment on the radiology forecasting?
Yeah, so basically we've got a data officer within our cancer MDT team, and she's currently looking into how we can potentially implement AI into our systems, because apparently it was identified that most of the UK hospitals are already using them, and they are helping them with tracking the patients, and it's particularly with the workforce of the MDT coordinators, because currently our MDT coordinators are also trackers, so they are basically responsible for all the patients who are on the suspected cancer pathways or confirmed cancer pathways. So depending on the site, it's quite a lot of work that needs to be done by one person. So it was identified that with AI implementation, we could potentially reduce this workforce and use MDT coordinators to support the clinical teams more. So at present, we've started the training with a co-pilot, because it's been introduced locally, and all our MDT coordinators went to have some training on that bit, because apparently it can help you with arranging your emails, or helping you to identify the tasks, to summarize meeting minutes. So it does, like, you know, those small jobs that you've got daily, it helps to reduce the amount of time you're spending on them. So yeah, currently we're just talking with our operational management for cancer services on basically going forward with buying, like, you know, with making it more official, and just introducing the AI to the island.
The other comment I wanted to make about the requesting of imaging during the MDT, it was quite an easy fix for us, because we just took the laptops, and whoever wasn't presenting would be requesting whilst the other person's presenting. The MDT coordinator then goes down to radiology immediately after the MDT, and we get dates for the scans. However, radiology are aware that they are not to send out any letters to the patient, because what we wanted to prevent and ensure doesn't happen, that they get some letter saying you've got an appointment because you've got cancer, before we actually have that clinic appointment with them. So radiology do not send letters out until they've had their clinic appointment or have been contacted by the clinical team. And I mean, there will be hiccups with everything, but it seems to be working quite well for us, and it shaves off a few days.
We did notice some improvement already with some of the patients being discussed on Wednesday afternoon in the MDT meeting, and then we see them in clinic next day on Thursday. By the time they're in clinic, we already have the dates for them for the additional radiology scans. So our team in clinic hands over the letter from radiologist saying, oh, actually your scan is booked for tomorrow. So we do see the improvement. It's going to take a bit more time to do a proper audit, but we've definitely noticed, yeah.
The other thing I've implemented is we have something that we call a results clinic. So it's where the resident doctors have a somewhat virtual clinic, and they can then add some of these patients onto that to request scans if they haven't been requested during the MDT for whatever reason. And that happens, you know, every few days.
Yeah, that's great. I love those ideas for the radiology, just to streamline it and actually give the patient information as soon as we've got it. I think that's very commendable. It's great.
Thank you.
Great, thank you. Trisha?
Yeah, just a quick question around how you're using AI. Just wanted to know, how does it work with the governance with GDPR and AI? And because obviously there'll be, when they're tracking these patients, information stuff involved.
So it's still a work in progress. We haven't introduced it yet, so we haven't gone that far yet. It's just we have to really move with all the, like, AI is now a part of everyone's life basically, and we really need to know how to use it, as you said, properly according to all the GDPR standards. But our hospital is quite new to that, so we are kind of just trying the waters.
Yeah, we are testing the waters.
Yeah, so it hasn't been implemented yet, but we're just on our way.
So the first phase, I think, is us all learning and, you know, getting training on it, using it for things like meetings and, you know, administrative tasks before we sort of work out the governance. But then we also want to liaise with some of the other sites in the UK that have introduced it for different specific cancer sites to see how they've done it. But first we need buy-in from our IT team, because they're looking for reassurances as to, you know, the fact that it's a safe platform to use. And in my last discussions with them, we had agreed that we would look at some of the other NHS sites.
Yeah, would you be able to keep me up to date? Because it's something that I'm interested in as well. But the GDPR, it seems to be a bit of a block. So that would be really good to know how it's actually working. Thank you.
Do you mind just dropping your email into the chat and we'll keep you updated?
Thank you.
Perfect, thank you.
Great, thank you so much, everyone. Thank you to the team at Nobles for joining us and for presenting. Any other questions, or shall we move on? Yes, okay, thank you so much, team. Max, back over to you.
Yeah, thanks, and thanks for accommodating me. I'm on the call with John, who's our co-cancer lead for urology in Salisbury, along with Tara from our cancer services team. And we, like many others, wanted to look at how we could try and cope with the very large number of patients being referred into our MDT that was causing complex cases, you know, to be rushed, and everything was quite difficult. We were also experiencing pathway delays because numbers were increasing, and there are downstream problems in the tertiary centre as well, which we can't directly action, but it does have an impact. So that's the background. We used a variety of methods as part of the improvement programme. I think the most important one, which has been mentioned already, is that it really did bring together the management team, cancer services, pathology and radiology, along with trust execs, with a common goal. And this program's been really useful as well. I've used it in various ways. There have been some individual sessions as well as the group sessions. The main change we made was to create what we call a low risk MDT. Essentially, it's a streamlining MDT, but we added to that a sort of scheduling meeting for time sensitive cancer cases in urology. That's particularly bladder and upper tract urothelial cancer, because they're the ones that metastasize early if they're high grade. And we did want to progress with non-medical prostate biopsy training, and we are progressing with that. But as part of that, we managed to bring on board an extra senior fellow for prostate biopsy delivery and training. So that was useful as well. You can see in the graphs, which haven't come across fantastically, but there is an extra slide if anyone does want to look at that. Since we introduced the streamlining MDT, the number of patients featuring in our main MDT meeting, which has everyone there, have started to decrease, which is really useful because it does mean that the complex cases are given a bit more time. And moving on to where we are now, we're getting a reduced number of patients coming to the main meeting. And I think the team have realized that, you know, it does not only have to be consultants or senior nurses who escalate problems, and people are much happier coming forward with cases that are being delayed and things like that, which I'm really enjoying. We've developed some of our MDT pathways and have plans for others, along with standards of care being already present but being updated. We've got a referral performer which has been worked on a couple of versions since we started, and that does help. And we've also changed our histopathology requesting to make it clear which cases are time critical clinically and which are simply on the pathway because they're on the pathway. I think there'll always be a difference there, and it's important to pay attention to that whilst making sure pathway cases aren't overly delayed. I think the lessons we've learned, you know, echoing similar thoughts earlier, I think we have made improvements in a short time. I think embedding those and making them stick will take more time, and falling back on bad habits is a realistic possibility. So we all need to guard against that. People have really good ideas, whether it's, you know, other members of the team, other industries, other specialties. And one of the nice things about this is there have been other urology MDTs in the improvement program, and we've learned a bit from them as well. And lastly, looking at future plans, it's been mentioned already about audit. We're going to look at the impact of our changes on our FDS target and pathways. We've brought in a formal chair for the MDT already with a description of the role, which is useful. We were going to look at consultant prep time for the MDT, but actually after talking to the team, we've gone another way and are going to give our cancer specialist nurses additional prep time for the meeting, because overall we think they'll be better at doing that job. One problem we have is cross cover for cancer navigation, which does not exist, and I don't know how to solve that without additional recruitment, so I'm going to continue banging that drum, and we're going to look at our MDT performance via our AGM, with a sort of soft AGM every 6 months and a proper formal one every 12 months. So no, I'd just like to say thank you for the opportunity to be involved in the programme. I think it's been helpful. The short-term changes I think have been quite useful. I think the longer-term changes and team culture I think will be the thing that leads to sustained change. So I'm well aware of the importance of that, and we'll try and get it properly embedded. But thank you. Bit of a whistle-stop tour.
Brilliant. Thank you so much, Max, to yourself and your team at Salisbury. I think, like we said, change doesn't happen overnight, and I think it's really great to see that your teams have started to work together better already. So thank you so much. Tara, did you want to come in?
Yeah, I did. Unfortunately, our MDT coordinator, Callum, couldn't actually be here today, so I do apologise for that. But I just wanted to say on his behalf, it's doing this improvement work has really helped with his morale. He is an exceptionally busy MDT coordinator, and I would say most of the time is rushed off his feet with the amount of work that he's having to do, particularly when trying to arrange patients for the MDT. So even this really simple improvement with introducing the low risk MDT, it's really has improved with his morale, because he's able to manage his time far more better than what he was previously. So it seems like a really small change, but it definitely has impacted his workload, which is fantastic. I know it's not directly linked to this as well, but we've also introduced a bot as such. So it's not AI, but it is a bot which will do some very manual process So we've got an RPA team, and we've managed to actually, I suppose, secure some funding to help with very manual aspects of the MDT, which actually records some of our MDT outcomes, some of our first appointments, and that's been absolutely wonderful. We are very close with our RPA team, so we are hoping that we are going to introduce more kind of manual processes to that bot's workload, I suppose. But of course, it's slow steps because we're not the only people in the trust who obviously want their help. But I just wanted to obviously say that.
That's really great to hear, and yeah, great to see that innovation happening. And in terms of the morale point, that's really lovely to hear. I think it's so important, and we're really hoping that's the case across the board. And we have seen that a lot of recognition from all the trusts for their team. So thank you so much for sharing that. The team at Nobles, do you have a question?
Yeah, it's not really a question. It's just we've noticed that in the methods and outcomes you've mentioned some tweaks in patient pathways for prostates. So this is something we're struggling locally to streamline the suspected prostate cancer pathways. Are you happy for us to send you an email to just ask about it in more detail, if you don't mind? Just it's interesting, like what work you've done, because it could be potentially something that we could implement locally.
Yeah, absolutely.
The urology MDT coordinator, and it will fall under my remit as well. So
yeah.
Yeah, absolutely. I don't know whether my email can be distributed, or I'll stick it in the chat. Maybe that's easiest.
Yeah, perfect. Thank you so much.
Brilliant. Thank you so much. Any other questions or comments? Brilliant. Well, thank you so much, Max, Tara, and the rest of your team at Salisbury for your hard work. It's really great to see. So last but not least on our list, we have Tameside and Glossop. We're just switching over. We didn't want to mess up your poster, so I'm probably going to present it now. Thank you, Robin.
Hi, everybody. So I'm Natalie Heath, so I'm representing Tameside Hospital for our breast improvement project. So I also have my colleagues on the call. So there's Anthony Edwards, who's our breast directorate manager, and Stephanie Ridgway, who's our cancer nurse specialist, who have all been involved in this project. So as you can see, we didn't choose as a team to use the original template provided to us. I think because we've been on a real journey, and we wanted to reflect that really in our poster to show you that we've been on this journey. So that's why we've used the roadmap. So we've really taken a staged approach as a team, which I hope is reflected in our poster, because it's really hard to capture all the different aspects of the work and the processes on one page, really. But we have used quality improvement initiatives like the driver diagram and SMART to outline the components and the relationships that are all involved in achieving our projects and trying to identify the aim. I think it's really important to highlight that as a team, our initial idea for this project was really around the implementation of a pre-MDT meet. But as we're currently undergoing kind of a full MDT reform as a team, we thought with our breast data being an outlier in our trust, that we'd start by developing our MDT pro forma, highlighting really in particular the improvements that we intend to make for our breast data collection. So what did we do? So we met as a team to identify the gaps on the pro forma and add the data that we thought was really beneficial to collect at the point of the MDT. And the rationale really for collecting at a point of MDT was so we're not doing it retrospectively, just to give our MDT coordinators and clinicians a bit of time back in the diary. So we took a really staged approach. We tested a newer version of the breast MDT pro forma in one of our MDTs. We have our MDTs weekly, and it is one of our larger MDTs for our trust. We briefly introduced the form to the clinicians and the MDT coordinators, and we figured out an aim together. And the aim was that we were going to make sure that we comply with 80% standard for cancer service data set for completeness, and to try and save time and efficiency for our MDT. So we were collecting data on completeness rate of COSD requirements, which is our cancer offset data. We received feedback from the team with regards to this and how it was working, and whether they felt that filling in extra things on the pro forma was time consuming. So our next step then was really to revise the pro forma for the next meetings. So we liaised with the MDT coordinator to ascertain from her how easy and how difficult it might have been to extract that data within the MDT, because we did recognise that obviously we need to make sure that the patients are fully discussed, and we want to make sure the flow of that MDT continues. So to measure our progress, we compared our data completeness from pre-testing this new pro forma to the previous baseline. Our previous baseline was in the 60%, so we knew that we wasn't doing really well. We summarised with the clinicians and the coordinators any feedback about what worked well and what didn't, and identified some more missing gaps really, or any fields that were a bit confusing or weren't working very well. So we made them small adjustments to the layout and to some of the mandatory fields, and prepared an updated version. And then we went on to test that throughout all our MDT meetings for a month. We provided a quick guide to the wider team, so the people and the stakeholders that were initially involved in the planning, we made sure that they were briefed at the start of the meeting. We measured the compliance weekly through our National Disease Registry and our Cancer Stats Live platform to ensure that we were meeting standards. We hope that we'll use this pro forma consistently moving forward, and we want to analyse and hopefully improve the target for 80% trust compliance for our data. We wanted to evaluate whether the time spent collecting the data had reduced or not, to ensure that we are streamlining the MDT and we're not putting additional pressures on anybody in terms of the discussion for the patients. We also reviewed any repeated errors or fields that clinicians were leaving blank, because of how rapid the MDT discussions tend to be, sometimes you can't capture everything. So we identified them further training needs. So the integrated final version of the MDT is now routinely working in our MDT workflow. So what we're doing now is really starting to explore simple digital enhancements that we could make, such as implementing a digital option for drop downs that are easy to click and prioritise during the MDT, and standardise some of that terminology, because we know that an MDT team is made up of clinicians, administrative staff, and not everybody understands. So I think as a team we recognise that, and we measured the data completeness monthly, and what we've started to do now is feedback via our breast speciality meetings. So we have a governance and speciality meeting every month, and we now are highlighting improvements via our cancer speciality pack, which I go and discuss with the team with regards to improvements in the processes for MDT, but then also performance as a trust overall. So what's next for us? So we're going to continue to monitor the data and assess any further needs for improvement. And I think we need to recognise that changes and improvements that we're making, as a lot of people have alluded to already, aren't going to be an overnight thing. So you're always going to go through this journey of start to finish. So when we recognise there's something else that we can implement, we'll go back to the start for further development and review. So our plans are to undertake quarterly reviews of the MDT pro forma and all MDT processes to ensure that our standards of care and the guidance is maintained. We will quarterly and yearly review our standard operational procedures to make sure that they're still in line with guidance and national targets. We'll continue to monitor our improvements in data and get feedback from the staff on how well it is working and what the impact of that is on the MDT. And our goal really ultimately is that we're hoping that we will be able to roll this way of working out to all our other MDTs in the trust once we've measured it for a few more months and we know that it's working. I just thought as well, just as a lessons learnt really for the team, that it's really important to gather the data, because ultimately it's leading really to better outcomes for our patients. and it's utilised in national audits and the National Disease Registry, and basically it's improving patient care and future patients' care that are living with and beyond cancer. I think as a team, like I said, we have gone through a bit of a journey. So we did rearrange our project initially. So I think what we've learnt really is that if you don't work together as a full MDT cohort, then it's really difficult to achieve the goals as a team. So every person really, with regards to managers, whether it's clinicians, MDT coordinators, everybody is really keen driving these improvement projects. So we recognise that now, and we're going to continue to develop our MDT and make sure that everybody's involved, no matter what level that they're working at. And I think I'd just like to reiterate what everybody else has said, really, that thanks for letting us be involved in the improvement project, and also for sharing all your learning, because I think for all of us as a wider cancer team, it's really important and crucial that we look at other people's services and we can plan and develop for the future. So yeah, that's us.
Brilliant. Thank you so much, Natalie, and to the rest of the team at Tameside and Glossop. It's really, really nice to see your journey reflected like this. And yeah, for pointing out the fact that it is so simple for everyone to work together no matter what. So thank you so much. And questions? Who do I have on my screen? Anthony.
Hi, good morning, everyone. So Anthony Earls, Deputy Visual Director here at Tameside. Just wanted to congratulate Nat and the team for the work that they've done in this project. And I think, Natalie, you quite rightly alluded to this is a journey. And it's a journey across all our tumour groups that we're working to, but especially in breast as well, which has multiple challenges, primarily due to its very high demand on services and high volume of referrals we get every single week into this service. And the team do incredibly well for its FDS and 62-day performance, but due to that high volume, we need, it's all around improving that flow right at the front door. So huge well done, Natalie and the team, and this project will continue, and it's been an exemplar then to move on into other tumour groups as well across the trust. Thank you.
Wonderful. Thank you so much. Does anyone have any questions or comments for Tameside and Glossop? Well, if anyone has any questions, then please feel free to pop them in the chat. Thank you so much, Natalie, and to your team for your work on this. And I think that is all of our posters for today. Thank you guys so much for your work on this. It's so great to see, and it's so clearly laid out. And we really, really appreciate the work that you've put into doing these. So I'm going to pass on to my colleague, Matt, who is going to talk to you a bit about evaluation.
Hi, everybody. So we're going to try and just get a little bit of feedback, because we often send things out and don't get many, so we thought we might try and capture you while you're here to do some feedback. So I'm just going to put a link into the chat as well. Bear with me 1 second. Which, if you haven't got a QR code, yeah, or don't want to use a QR code, this should hopefully also take you to the survey. Yeah, we want to try and capture some feedback on the program. Obviously, thank you very much for some of the kind comments already, but it's really important for us to hear your thoughts. Please be honest, anything you think we can do better, because it's good learning for us. We like to role model our improvement methodologies. Yeah, please do. I mean, I think, and while we'll just give people a couple of minutes. It literally should take about 2 minutes, 2-3 minutes to do. But I think I'll just talk a little bit around some of the thoughts and comments from today. So I was going to talk a little bit about sort of sustaining change and sustainability change, but interestingly to me, I think the speakers today have covered all the points I was going to make, really. So which is really positive to hear, to actually say it is around that it does take time. It takes time to build these sort of habits within a team and practice them and keep them going, it is it can be quite hard to sustain this. But creating a sort of the thing around like the normal behaviour of a crowd can sort of overpower some like desired behaviours of individuals, and that getting that team view of like this is where we're going to do, so that the thing about having a problem statement, stuff like that, can be really positive. Like it sort of harnesses everybody into the same view. We've heard from the people that there has overcome some resistance, and understand. People have obviously tried to take time to understand why people feel concerned about it. And change is scary, change is difficult, even when things are not great. There's nervousness about changing stuff. It's effort, it's learning something new. So understanding all that and putting in place measures to tackle that has been really positive to see. So I think it's for us, I think it's just a thank you from us as well. As Stu has already said, like today's been really, I think, empowering, because we've heard a number of amazing things, but real drive and energy to continue the tasks. Like, see, we've always felt this is a starting point, not an end point, and we're really grateful that you've given up your time to be part of this. But it has also, I think, we're really pleased that it has given that starting point for you to think about these things and really progress them, because there's been some really fantastic stuff that we've heard about today, and also really fantastic visions for the future, moving it on. So, I mean, I think, hopefully this has given you that starting point, but sustaining it like this bit is often the hardest bit now. It's like, okay, right, with the emails will be finishing from us, the chivying is gone, and so like taking that energy and drive and really taking it forward. And there will be steps back, there will be difficulties, but taking this forward, I think, is going to be really powerful, really positive, and we would love to hear, in the future from you when things have kicked in, and because I think we can see from the power of this is that everybody's in a similar boat, and sharing good practice and sharing the things you've done can be really positive. Obviously we've managed to get some people to share through this program, but we're really keen to have more people that we can put on, say, okay, this person or this team have done this elsewhere, as we progress through the journey of improving sort of cancer and MDT programs. So thank you very much for that, and hopefully everyone's had a chance to fill in a survey. Maybe I don't know if I can see if we've had any responses. Hopefully we've had 23. Right. We will send links out afterwards as well. So if there are people, obviously some people had to drop off to go to MDTs, ironically enough, which is good. We don't want it, that would be bad if we got in the way of MDTs happening. So we'll hopefully capture them all. But I think just sort of taking last sort of messages, please do keep going. Like it can be, it's hard to find the time, but I really hope that as we all do as part of this program, I'm a small part of it. There's people behind the scenes, Robin and Dua and Crystal and Alison, who's done a huge amount on this, and the coaches as well. So please do continue, and please do stay in touch. We're always available. We have Robin especially has a huge links across the whole of the NHS. So if we ever need to find a helpful friend, Robin is normally the person to reach out to. Right, I will stop rambling because I think I've done enough of that. And hopefully we've captured some feedback, and I will hand back to you, Dua, I think.
Great. Thank you so much, Matt. And yes, we will send around that link afterwards so people can fill it in, and anyone who's dropped off can fill it in as well. And we will also make sure that we will share the posters too. But just echoing what Matt said, I think today has been really empowering. It's been really, really great to see the work that you guys have done. Thank you for sticking with us throughout the last few months. It's been, really wonderful. This is our second cohort, as we mentioned earlier, in the project, and it's been really, really great to see the changes that you guys have made, all those small wins and all the work that you've done together, and seeing you work so well together has been really lovely. So thank you so much. So thank you to all of the trusts for taking part in this project and for bearing with us in all of our emails and for coming to the learning sessions and doing the self-assessments and making those changes and making the posters. So thank you so much. And thank you to, as Matt said, thank you to our coaches from NHS England for all the work that you've done as well. It's been really, really lovely to have you guys on board with us. And to our QI coaches from Gosh as well, Caitlin and Nawanthi, their work has been really, really brilliant. And we hope that you've enjoyed working with them too. Personally, just thank you to Robin, Matt, Alison and Crystal for just being amazing and for putting so much work into this. It's been such a great project and we're really glad that we've managed to run it again. But yeah, thank you so much to everyone who's been involved. Like I said, we will share everything afterwards. Everything is usually on the Futures Workspace, any recordings and the presentations and the links, and also the posters will be up there as well. Does anyone have any last thoughts, comments, questions that they want to bring up? No? Well, thank you so much. It's been really, really wonderful. And we hope to see more of your improvements in the future. And please do stay in touch as well. Yeah, please do come to us. We're really, really intrigued to see how things are going. This isn't just we do the project, you never speak to us ever again. Like, we are always around. So please do keep in touch with us. But yeah, thank you so much, everyone. I hope you have a lovely day.